A very good evening, everyone. Welcome to our webinar on shaping the future of cancer care. This is a part of our campaign, Cancer Care Matters, launched on National Cancer Awareness Day on November 7th in association with GE Healthcare. We have with us Dr. Venkatesh Rangarajan, Head Nuclear Medicine and Molecular Imaging, Tata Memorial Hospital. We also have Dr. V.S. Ajay Kumar, Chairman and CEO, Healthcare Global, and Karan Verma, Head Digital and Care Area, GE Healthcare South Asia. Without further ado, let's begin with you, Dr. V.S. Ajay Kumar. There has been a significant rise in high-risk cases of cancer and the overall cancer burden post-COVID. As an oncologist yourself and an entrepreneur in the cancer care, what is your opinion? And have virtual consultancies been useful in these times?
Thank you. As we all know, being an oncologist for several decades, one of the most important things in cancer care has always been early detection, and also the fact we have to give first time the right treatment. You know, the advances which have happened in cancer care is because of the better awareness, and obviously we are seeing early cases with better awareness. But during the COVID period, one of the things was there was a collateral damage. Because at that time, because the entire nation went into a lockdown and there were no movement, no transportation, and the fear of COVID going to the hospital. So imagine a patient who has a lump in the breast or a lump in an ulcer in the mouth. You know, they would hesitate to go to the doctor, even to the doctor's office or to the hospital because of the COVID fear and also the logistics. And this obviously caused a collateral damage where people started coming in after the lockdown at a later stage. One of the things, of course, was the question you raised about virtual consultation. At HCG, we were always doing a lot of virtual tumor boards, talking to the patients because we are a national network. So we were well positioned to do the virtual consultation. Obviously, we created a war room and a hot and a 1-800 number where people could call and get information about cancer, if they have a problem, how to talk. So we used extensively the virtual consultation, phone consultation, so that at least we can alleviate some of the concerns they could have during this period, trying period. That is why during the second wave, we were able to handle this much better. We were much better prepared, and also the patients were well prepared and well nuanced into this. So these things helped us to overcome the second wave far better than the first wave. The other issue was the COVID itself. In cancer patients, there was a fear. But one of the statistics we done in our own internally and put it out showed clearly there was no increased mortality from COVID patients. That was the fear we had, and it was as much as the general population. So that factor was not there, at least. The fear that COVID will attack cancer patients more, the mortality may be more.
Dr. Ajay, you also spoke about, advancements in technology. Will that make managing cancer easier? Will this affect the way private cancer care hospitals function?
Yes, the technology obviously has made a huge difference. When we look at cancer, you will hear more from Rangarajan, I'm sure, is that early, right diagnosis, proper staging, and proper pathology are the most important things. For this, technology advances have helped us a lot in properly staging, and the digital pathology and the genomics. All of this, making sure that right patient gets the right treatment at the time has become crucial. So one of the things we did in the past was, based on randomized trials where nearly, 30, 40, 50% or more patients would not benefit from treatment. Today, in the era of precision medicine, because using some of these technology, data collected, and putting the data together and the recall of the data has helped us to make sure that the patients more or less get the right treatment the very first time. So India particularly, when we talk about cancer care matters as an opportunity, and it has actually leapfrogged to a different level, because it is like some people going from land phone to suddenly smartphone. That is what is happening in India today in cancer care, where we are able to leapfrog using technology to the limits. And of course, now with the new things coming, metaverse and augmented reality, I think this will bring, tier 2, tier 3 cities also the high end of cancer care very quickly. So it's very promising how technology can be leveraged for proper cancer care.
Right. Moving on from what you just spoke about technology in cancer care, Dr. Rangarajan, I would like to also know your opinion as a nuclear medicine and molecular imaging expert. Could you tell us about the latest tools and technology for early detection, staging, and treatment?
Yeah, so actually this, you can say like there are majorly three pillars. One is early diagnosis. So we'll put all diagnoses in one, then surgery, then radiation oncology. These three are the major areas in which technological development has taken, and each one has led to the improvement in the other. So to begin with, in the beginning part of our this 2000s, this part of our century, the development was the hybrid imaging. The PET scan and the CT scan were fused together, not just physically, but also with the help of the technology. And there we were able to have a situation where we were having a PET scan which talks about the molecular imaging part, along with the anatomy, which is the CT. And these two, way from 2001, almost you can say every 3 years there has been a development in the technology of the hybrid imaging, and one generation becoming better. I mean, the next generation being far superior than the other generation. And from the digital, from here came the maturity of the digital technology. So we were going from analog imaging, we were going to the digital imaging, like for example, digital mammography. So the entire spectrum. And then, for example, precision radiation oncology, that was also getting into that largely because they were now, earlier they were taking conventional only CT scan images. Now they were having PET CT images. A better quality of data was available, therefore the outcome was better. And last but not the least, the development of what's called as image guided surgery and your Da Vinci and other type of the new generation of surgery. So, it is not just diagnosis, but the entire spectrum which has benefited from technology. From the nuclear medicine point of view, hybrid imaging, it's a very art word to use, because we are using two modalities. One is something to look at the anatomy, which is CT. And so we have the PET CT and then the SPECT CT, and then the MR, which was again fused with the PET. So we have PET MR. And all these equipments, you can say each of them are, you can say something like an era on themselves. They have made such a big difference. The first major difference is that in a patient who has a high pre-risk test possibility of having a malignancy, the outcome of the test was better. So in a suspicious patient or in a patient with a very high risk of malignancy, we were able to diagnose it very well. Digital screening techniques across the board brought down the radiation burden to a very significant level that, it could be offered very easily and without the fear of radiation. The second thing is, once we have a diagnosed disease, is the staging. And there I would say PET CT has made a huge difference in right staging, what we call a stage migration. And that helps us to identify which are the patients which will be requiring the right type of treatment. So you can put it this way: the patient who would not benefit from surgery, now we are saving him from a futile surgery, and a patient who would benefit from a surgery, who otherwise on radiology had some other type of imaging abnormalities which could have been earlier passed off as inoperable, now becomes operable. So in both ways, there was a downstaging and upstaging depending on the type of organ system we are talking. So there has been a very excellent way by which we have got the staging. After the staging, as the precision technology, whether it's radiation oncology or the precision molecular medicine, which are used by the by the medical oncologists, this is not something which will benefit every patient at every given situation. And then, so we need to have a very precise way of examining the response. So the conventional response, which was an anatomical based response, was not giving the right answer most of the time. So when we have the molecular component and also the anatomical component, the response evaluation was better, and we were able to identify those patients who are actually improving clinically, but actually who are not showing much changes in the images. So it has actually helped us in all the various stages in the treatment of cancer. So this is just to say that there has been a huge technological development that has brought down radiation, brought down the cost, made the entire imaging more efficient, and made the entire treatment planning and the treatment outcome better. So this is a very simplistic way of putting it.
But Dr. Ramrajan, picking up from what you just mentioned about molecular imaging, how critical is the role of molecular imaging in cancer treatment?
Yes, molecular imaging was there even before. Like, for example, when a patient was having a thyroid cancer, we knew that the metastasis of thyroid cancer from a differentiated thyroid cancer has the ability, the cell has the ability to concentrate iodine. So basically, this is a molecular component. I mean, the cell has got a unique component using sodium iodide importer that it can actually, it can track, it can take up the iodine. So when we are using isotopes, so the isotopes goes there and we are able to we are able to pick it up on the SPECT scan or the gamma camera. And when we connect it with a hybrid mode, we know exactly the anatomical location also. So the very major change has been the use of FDG PET, the fluorodeoxyglucose. That is the molecule which we have been traditionally using because it looks at GLUT receptor. It's one particular type of molecular gateway which is overexpressed in most of the cancers, not in all cancers, but in most of the cancers. And that helps us to identify, to pick up the disease, because otherwise we were looking at the disease and we were classifying them on the size criteria. And then we were able to identify that, irrespective of the size, because of this molecular component. And this, what was with FDG was immediately, I mean, very soon we had several other molecules to come up. We had we were having newer molecules which were being picked up by different type of tissue cells, neuroendocrine tumors, which are looking at a different component. They have a different type of service. So we have a component called a gallium dotatate. Dotatate is a small peptide which gets localized wherever the cells are expressing the somatostatin receptor. Or in case of prostate cancer, like for example, the prostate specific antigen, which is overexpressed. So now we have a huge type of several new gateways, what you call as the cellular gateways, which we are able to identify because we have identified molecules which specifically go to them. The specificity is very important, what we are trying to talk. And that when it is labeled with a chelate and it's labeled with a isotope, and which is what we detect well on the PET scan or on the SPECT scan, makes it very unique. And that being a part of a hybrid imaging, you get exactly your abnormality in which particular tissue, and you are able to isolate and we are able to identify which tissue or which anatomical zone it is. So all the three components of the disease the pathological process we are able to identify. That's the uniqueness of molecular imaging. Second thing is when you are using therapy, one of the anatomical changes may not take place at all. But the molecule switching, what we call as the molecule switching, which happens when you treat many times with this very precise type of drugs, immediately the capacity of the cell to take up many of these markers like fluorodeoxyglucose or the somatostatin or all of them, they immediately go down. So immediately on a follow-up PET scan, we are able to identify, in a case of a lymphoma or in the case of any other disease, we are able to see that the drug is actually acting. There is a good response. So we are able to identify the responders and the non-responders. This is a very crucial thing in oncology, because it is very important for us to identify the non-responders early in the disease, so that we can go to the next level of treatment. And that treatment maybe there may be additional risks involved, but then we have identified the right amount of patients who will be able to benefit from that. So this is a very simplistic way of putting this problem.
Thank you so much for explaining that to us in such brief detail. I'd like to move to Karan to you now. And also if Dr. B.S. Ajay Kumar could also add something to it. What is the meaning of precision care in cancer treatment? Karan, would you like to go first?
Sure. So I think Indian Express is also looking at this series to be viewed by the citizens and the general non-clinician folks. So I think it's really important for them to understand that cancer is moving towards more and more high precision. So what does that cancer care moving towards high precision mean? The opposite of high precision is high variation. And if you see, cancer is not one disease, it's 100 diseases, right? And even if two people have the same cancer and the same organ affected, the tissue characterization of the tumor, the way the tumor will react to various therapies can be very, very different. So the whole idea is how do you reduce clinical outcome variability by catering the therapies and including, the way you diagnose and then the therapies that you use and the combination of therapies that you use. As Dr. Rangarajan said, that you use not just one, but a combination of surgery, radiotherapy, radiation, and then of course, chemotherapy. So that combination and the amount of dosage of radiation, etc., and over a period of time that you give can be very different for two different patients, even if they may have a similar cancer and a similar organ affected. That's what one meaning of precision is. Now, how do I have a plan for patient A, which is unique to patient A, given their genomics, demographics, tissue characterization, etc. The other thing is, of course, also looking at variability in terms of the various experiences. So, for example, today, Dr. Rangarajan mentioned nuclear medicine has progressed a lot. Imagine if I have PET CTs across, tier 1, tier 2 metros, and the nuclear medicine professionals across these may not have the same set of fields. Is there a way to connect all of them and have standardization of protocol in such a way that the outcome of care is really great? That's again increasing precision. So for GE Healthcare, it means different things, but at the end of the day, how can GE enable Dr. Ajay Kumar and his team at HCG and Dr. Rangarajan and his team at TMH to deliver more accurate, precise, customized therapy and hence better clinical outcomes for the patients? That's what it is.
If we talk about also affordability, can digital and AI make healthcare more affordable?
Absolutely. In fact, two key issues in cancer have been accessibility, and second is also an anxiety around, am I getting the right therapy? Everyone wants to take a second opinion. It can potentially become a terminal illness and it's very high risk and everyone has very high anxiety. I think digital can solve for all of that. Today, when a person has to go from, let's say they're staying in a tier 2 or even remote and they have to go to Bombay or some other metro place to get their therapy done. And these are multiple sessions which have to happen over a period of 15 days, 30 days, etc. The amount of cost incurred in a hospital is obviously steep. And, everyone like Dr. Ajay Kumar and, Tata, they are looking at reducing that cost and making it more affordable. But the cost of living, in a different city and the productivity loss that you have because you can't go to work, and some family members also have to accompany you, is almost equal. So you're not only not earning, but you're spending on travel and living, and then you're spending on expenses. So a combination of what Dr. Ajay, HCG has achieved, what TMH is doing today, spreading across, Tata is spreading all over India to bring precision health and entire set of therapies closer and diagnosis closer. But this can be aided a lot better with digital tools.
Dr. B.S. Ajay, I'd also like to know your views on the same, adding to what Karan just mentioned. And also if you could add on some points about what are the few current challenges that providers face in delivering cancer care.
Yeah, I think as some of the panelists discussed, issue facing India, particularly today, is accessibility. HCG with the 25 centers across India, we have made it accessible for nearly 53 crore of population cancer care. But one of the things where technology has been leveraged is for example, you cannot have experts in all the centers. So one of the things in the past, like what Karan said, people go to major centers. Today, we feel we are on the verge where people don't have to travel all this distance. So take, for example, place like Ranchi, place like Cuttack or Mumbai or Nasik, where we have high technology, PET scan, high-end linear accelerator, which was not there even a decade ago. We were just doing more cobalt therapy. So the transformation has dramatically changed how we can take care of our cancer patients, and using the, like virtual tumor boards, using data collection across country. One of the challenges is, for example, if they come to our Bangalore Center of Excellence, there we know the data, the outcome. Can we have the same outcome if they stay in Nasik or in Cuttack or Ranchi? And that is the greatest challenge in oncology care today across India. The other issue, of course, is the fact, as I said, cancer can be treated only in the right way the first time. Access to technology, knowledge will obviously provide that, but the issue is the financial. With us, with all the schemes and all we have, no, we are not able to do the right thing, because there are some limitations. So one of the things which private institutions face is, how do you deliver a patient the right treatment? But what happens if the patient cannot afford? What do you do? How do you bridge the gap? That is why, we have proposed several times a universal healthcare like what is there with no limits. Whether rich or poor, they should get the same treatment. That is the idea. Rich or poor, they should get the same treatment. But that is not happening today in India because of this great disparity. And affordability is not there. A lot of people want to pay out of pocket. So at some point, if you have to treat cancer the right way the first time, precision medicine, organ preservation. For example, so many mastectomies are done today. Even today, there is no need. There is no need to do a laryngectomy. There is no need to do, colostomies. Today, we have transcended above where people with cancer can have high quality of life and also live longer. Take, for example, lung cancer. What was, like what Dr. Rangarajan said, what was like 9 months to 1 year people living. With the advent of, biotherapy, immunotherapy, which has taken a huge role in advanced cases, even 5 to 8 years or longer. So the tremendous development has happened globally, and fortunately, India is very much there. But India is multiple countries. You have 350 million in India, which are affording, which are affluent, which is equal to United States, but we have 900 million, which we cannot access this. So how do you make this fill the gap is a challenge for us. But still, having provided for 350 million urban India high quality of care itself is an achievement, which is not unfortunately recognized because we put everybody in the whole thing in one bucket. So how do we make this meet the challenges is something where technology can play a huge role. We are talking about, mixed reality. We are talking about, virtual tumor board, accessibility. All of this will help to improve the quality of care and definitely bring down the cost. Because, like what Karan said, people don't have to travel long distance, height can be done. So we are on the verge of that, and the future looks very bright, provided we position ourselves properly and address this forthcoming issue, because India is going to be one of the largest cancer care, unfortunately, next to China. In the next 5 years, we are going to double the number of cancer cases. People live longer, lifestyle disease, cancer is chronic disease, breast cancer is increasing rapidly. So we have to be prepared for this in a proper way. And that is what I think we have a great opportunity to leapfrog if we prepare ourselves.
But Dr. Ajay, you spoke about being prepared for, situations. Are hospitals coming up with new solutions in case of emergencies and unprecedented times like COVID?
Yeah, definitely. Like I mentioned, the second COVID wave, we were so well prepared. We were able to handle flawless. So I think the COVID has taught us a lesson, and COVID has really told us that for regular follow-ups, even home care is a big thing. how we can go and draw the blood from home. Simple things like that. People don't have to come all the way to the hospital for a blood test, and how we can use the, smartphones to contact them and use the virtual, even if they are in tier 2, tier 3 cities, we can do. Almost everybody has a smartphone now. I think this is where the future will make a huge difference, where people don't have to come to the hospital for everything, except for possible just treatment. All the follow-up, some of the things can be done, and we can even involve the referring doctor, family practitioners, and through a virtual call, we can advise them what to do, how to manage the patient at a distance. So this will be the future. And with this, I think we are very well prepared for any emergency like COVID in the future. This has taught us a very good lesson.
Right. Karan, I would like to ask you, we just heard Dr. B.S. Ajay Kumar and Dr. Rangarajan talk about the advancements in technology, the challenges that we're facing in cancer care. I'd like to ask you, from the solution space, what can help providers increase clinical and operational efficiencies while keeping patients at the center of care?
Absolutely, and all our esteemed customers like HCG, Tata's, all of them are always trying to do that for the patients, right? For all of us, they're trying to increase the quality of care at all points of time. They're trying to reduce costs, improve affordability. They are trying to increase efficiency of their system, people, because you have limited number of radiologists, nuclear medicine, oncologists, etc. So it's a challenge that our customers face every single day. So every technology and every solution that we're trying to bring, we work towards that. But what you bring here, very importantly, is also the customer's customer, which in this case is the patients, right? And I'll give you one example. When we launched, Pristina, which is our digital mammo solution, we also kept in mind, besides clinical, having very good image quality, diagnosis, all of that is obviously critical. But we looked at the patient and we realized that one of the biggest issues with patient when they go in for digital mammo is the discomfort, right, due to compression. And we said, what can we do about it? And one of the ideas came in is, what if the patient is in control of the compression? But the challenge there was clinicians felt that, if they are going to, the patient will do the compression, they may not compress it enough for good image quality. When we actually ran, trials pre-launch, we realized that, the patients were actually, they were told, first of all, that compression is important for image quality and good diagnosis. And we found that they ended up actually compressing a little more than what on an average a clinician was doing. But because they were in control, they were actually able to, feel a lot better about that whole experience. The classic case of better clinical outcome, but at the same time, better patient experience. So I think all of us have to work together to discover such insights while looking at solutions.
Right.
Nikita, may I add something to, because to just answer to your question, you were asking, how are we bringing about operational efficiency to bring down, to overall improve the efficiency. So I would like to add certain points which is sort of unique to us. If you take, for example, some big hospitals like Tata Memorial Hospital or this HCG Bangalore, here the total number of patients who undergo PET scan is approximately double the number of patients who undergo PET scan in a given time in a per machine compared to, say, a country like United States or Germany. So we are actually trying to stretch across the patients so that we want to bring down the cost. And second, we want to decrease the waiting period. We want to operationalize and maximize the capacity of the machine. So these are all certain and same thing in radiation oncology also. The total number of patients who undergo radiation treatment in our country per machine is almost double than that of a global average. So if you take any major equipment, diagnostic or therapeutic, we are running almost double. And these are all certain very unique things which I'm sure many other countries can even copy. But we are not trying to compete with anybody. We are just trying to do, just to make it efficient, so that our affordability, see, as Dr. Ajay Kumar was saying, that we have to make the technology affordable. And one way by which we can make technology affordable is to make the whole process very, very efficient. That's number one. Number two, this whole digital explosion which has taken place in the last 15 years, everybody has benefited from you, right from the laptop or from the high-end equipments like PET-CT or MR, etc. Everybody has benefited out of that. But more than that is the indigenization. Unless we start making equipments in our country, we develop equipments in our own country, the prices will really not go down to that level where it will become very, very affordable. That's number one. And there I think I would want to compliment people like Karan and all who have done very good job in GE. They have developed even high-end equipments like PET-CT. So that's one thing I wanted to say. The last but not the least, we have to create several novelties, of bringing about more and more. Like, for example, in my department, in a day, I see around 20, 25 DVDs and CDs which come from across because the patients these days, they don't want to come for a follow-up and get a PET-CT done here. They get the PET-CT done in their own place. And they just get it reviewed, and we try to, make it the way it is to be made to the treating physician so that they can take the next logical decision. So these are all certain things which are very, very unique to our country, and I would say we have really gone out of the way to see to that we create this to create this great efficiency to bring down the cost and bring down the waiting periods.
Dr. Rangarajan, I'd like you to hold the thought there and move a little bit further into this discussion about importance of technology. And you just rightly mentioned about digital exposure in cancer management. I'd like to ask you: is theragnostic the future of cancer care? Can you explain to our viewers and audience what it's?
Yeah, what you can say is theragnostics was very much there. So one of the earliest therapy was giving radioactive iodine to a thyroid cancer patient. That was there even before the telecobalt and all were invented. But today we know the precision by which we know as to what was the mechanism by which the iodine went to the particular tumor cell and how it irradiated. So now in theragnostics, what we're trying to do is, on one hand, we are using, as I told you, this very precise peptides and several other new molecular targets. And these targets are labeled with positron emitting isotopes or with SPECT emitting isotopes. And that is the diagnostic component. And once we find that in the disease or in the metastatic state of that particular disease, this agent is concentrating in good quantity, then what would happen is that the same peptide is now labeled with a different type of isotope, which emits a different type of radiation, but this time we'll be able to deliver radiation to that particular region. So, when we know radiation delivery, we always know about brachytherapy and the teletherapy and the cobalt therapy. They are very good. But, here what actually happens is there is a better internalization. The peptide is actually entering into the cell or the tissue, and what it is carrying, the isotope, is actually delivering the radiation there. So what you can say is, this is a more efficient way of delivering radiation, and the radiation is likely to cause less amount of damage because we have several other types of isotope. Like, for example, now we have alpha emitters, actinium-225, radium-223. These have got a very low penetration level. So even like, for example, in certain metastatic regions like bone, it will deliver the radiation so that the metastasis heals, but it will spare the marrow so that the marrow suppression doesn't take place. So this combination of diagnostics and what we have seen on diagnostics to take it to the next logical step of treating, we call it as theragnostics, and we always now call as theranostic pair. That means one molecule for diagnosis and the same molecule and a different isotope for treatment. So now we have around 5 to 6 successful molecules, successful pairs. And what we feel is that as we try to understand the biology of the tumor, now it is because of the better understanding of the biology and the mechanisms of cancer that now we have developed so many types of what you call as medications which are used by the medical oncologists called targeted therapies. But this targeted therapy is not going to work on all patients in all situations. That has been very well understood. And this imaging, the theragnostics, will be a very good way by which we can image. And the therapeutic component of the theranostic pair can actually supplement this type of activity which is being done by the medical oncologist. And this is bound to improve the overall survival and the efficiency of the treatment, and also decrease the toxicity. And here we find that there is lot of scope. And now, for example, we have now a new molecule called FAPI. And this particular molecule, it looks like it's going to be a big winner in the near future. We're talking of something within the next 2 years, where we have a very successful diagnostic FAPI. But the therapeutic FAPI, there are some teething problems. But once we solve those problems, FAPI can be a very, very effective mechanism. FAPI is a very, very precise peptide, and it is labeled with the chelate and the isotope. So the gallium FAPI or a fluorine 18 labeled FAPI, this will be for diagnostic, and lutetium FAPI or actinium FAPI will be the therapeutic pair. So I find it's very exciting, and just and the thing is, for example, if you are able to label them with an alpha emitter, your efficiency. Now, for example, proton, we all talk of proton therapy. The quality factor is only 10. You can say 10 times more effective. But if you are able to deliver an alpha particle to a particular region very precisely, your factor is 20. So, it will be a very good turning point. So we are very optimistic about it, and we feel that could add. So theranostics is considered as a priority. And for example, I read today in one of the articles, I think in RSNA, that Australia has identified theranostics and precision nuclear medicine as one of the thrust areas of their national importance for research and support. So this is something which I'm sure will, and in India also we have made tremendous progress in theranostics.
Thank you so much for explaining that to us in such detail. Karan, I'd like to ask you, and we're also running out of time, so this would be my last question before we slip into our Q&A. Can collaborations and multi-stakeholder models also help in making cancer care accessible and affordable?
I think it's a very integral part of making cancer care affordable and accessible. For us, collaboration means two things. One is we are constantly collaborating with our customers to develop solutions. And any of these solutions that we do, there is a tremendous amount of pre-market clinical validation, workflow validation, technology accuracy validation that we work with institutes like HCG and Tata before we bring it to market. So for us, that's an important part of collaboration to make it accurate. Second part of collaboration for us is that we know that as GE, especially in the digital solution space, we may not be able to do everything. And we are humble enough to partner with other organizations, especially startups. So we have a structured accelerator program in which we work a curated set of startups. Every month, about 150 startups, in India apply to us as part of that program, and we curate about 5 of them, and we work and we bring their solutions to market. So that's again a part of collaboration. But the third part of collaboration is also where partners within our various customers are collaborating. So if there is a single specialty player like an HCG, for example, offering oncology, and there are small hospitals in tier 2 who are not able to offer oncology the way an HCG can offer, we try to bring the two of them together, as someone who understands and knows both of them, so that they could collaborate and establish a shop in shop and increase, the amount of care and the width of care which is being provided. So we're always on a lookout to increase collaboration for oncology in these 3 ways.
Right. Thank you so much, everyone. We have a few questions from our audience. Meenakshi Suri is asking, what are newer modalities for early diagnosis of cancer? If someone could take that.
Yeah, I can answer that. The newer modalities include, like for example, there is a genomic testing for India. Head and neck cancer is very prevalent. And simple, we are now having modality where simple mouthwash do a early genomic indication of a possible oral cancer. Early detect very similarly, for example, breast, there are areas where we can do early detection to thermo imaging, we can early detect even a small lump in the breast, which can, once we take a very simple and very easily. So these are some of the promising things for early detection. I do believe early detection in future will be through even a blood test, looking at cfDNA, what we call as through blood test, we may be able to see which are the person who's likely to get cancer and biomarkers. So there are promising tests in the future where we can. But one thing I want to add here is very quickly, unless India goes into R&D work with a huge data we have and academics, we cannot become leaders. If you have to early detect cancer, even manage it properly, I think we have to get into data collection, curating the data, look at the data in Indian population, and then decide how we should position ourselves for future. So these are all in a way totally integrated. The startups, the early detection of cancer, managing, doing the data, all of that are very, very much interrelated for us to win the war on cancer.
Dr. Ajay, you spoke about early detection. We also have a question from Anupam Pandey, who's asking what can we do to ensure maximum possible awareness on cervical cancer. Also, he wants to know your views on the role of AI and ML in cancer detection.
Yeah. Regarding cervical cancer, the fortunate thing is cervical cancer is coming down significantly in India. With the pap smear and hygiene, both in men and women, over the last decade, the cancer, particularly in urban India, the cervical cancer has dropped significantly. And that is related to human papilloma virus. And even in rural area, because of proper pads, women are using now hygiene pads, it has come down significantly. We hope like in the West, we can win the war on cervical cancer by these preventive measures. And of course, there is the vaccination which can be given, which has been tried, and that has got very promising results. Regarding the AI in cancer, I think, like I said, data collection, AI, getting the proper report. When we look at a digital pathology and where we are already using AI. For radiology, the risk fact, we are already using AI. And the good thing is these AI platforms are giving you to put your own data on it so that we can individually collect data and see how we are doing. And it is going to really spit out actual report as we go forward. So accuracy in across the country, in a big country like India, accuracy and expertise will come. And AI will help us a lot. But the thing about AI is we should learn from Watson experience. AI is not static, it's dynamic. It has to be consistently, we have to review and change. Cancer is a dynamic process. Cancer is an enigma. So cancer care requires a lot of mathematical calculations to see what direct radionomics, genomics. There are so many factors. 45 years. If people ask me, are you an expert in cancer care? I say, no, I'm not an expert. It is difficult, and it is, we are probably stretched because it's such an enigma, but we are on the right path. And particularly in India, if we collect a lot of data, and Indian genomics itself is different. We follow the Caucasian model. So we have to look at that. Is why partnering with organizations like GE, which are very much, involved in healthcare, help us a lot to move forward in this, solving this problem of this enigma.
Thank you so much, Dr. Ajay. There's also another question from Vimlesh. He's asking, can someone explain what is immunotherapy and how does it benefit cancer patients?
Yeah, immunotherapy is a form of therapy where you make your own body fight against the cancer. As we know, cancer cells may be there in all of us, and our body suppresses because our body immune cells prevent. Actually, it prevents it from spreading to some organs also. Immunotherapy is called checkpoint inhibitors, where actually it makes your T cells To put it in very simple term, imagine a war where your T cells are fighting the cancer cells and they get exhausted. Cancer is winning. So these immunotherapies actually program it such a way the T cells can go and kill the cancer cells more effectively. They are actually newly energized. They go and kill. So this is what immunotherapy does, and immunotherapy has provided phenomenal results. Unfortunately, it is still patented and expensive, but we are seeing some long-term survivors with immunotherapy, and it is very promising for the future.
I think there is some technical error, but I think we did get a gist of what you answered about Bimlesh's question. We also have another question from Prabhat Agnihotri, who's asking, what is the role of computer-aided design in cancer detection?
No, the computer-aided design is a very vague word. It's a very big area. Okay, with CAD you can develop better equipments. You can develop good detectors. With CAD you can do a lot of formulation, postulation, modeling, etc. So it will help you for better development. And the second thing is that artificial intelligence itself is a type of computer-aided design only. The way we plan the artificial intelligence model, the engine. So you have one set of AI engines, tools for image reconstruction. The other one is for risk prognostication and then the third one, we can also have AI engines to identify which are the patients who are reasonably doing well, but who are having a type of cancer which is better, therefore can go for more expensive treatment like proton therapy or immunotherapy. So instead of saying cancer aided, computer aided design, I would say computer aided modeling will help us to identify the various aspects of cancer. And one of the things is this artificial intelligence is going to make a lot of our lives very easy, because it's as a matter of fact, even better image reconstruction techniques has brought down the radiation burden for conventional imaging. Now what happens is some of the hardware and the equipment required also will go down. So what is happening is better computing, and with AI and with better modeling, that's very important. The word is modeling. We are able to get better images, better outcome with a lesser expense of hardware. So we can have a relatively cheaper hardware and we can produce. This year in RSNA, there is an introduction of a new MRI, which is not so powerful like the other MRIs, but because it is so nicely made, designed using artificial intelligence, the net output would be that it be able to give a very good image, as much as a 1.5 Tesla or a 3 Tesla MRI would give. So all these things are, all are computer aided modeling and computer aided design in that way. So there is a huge way by which computers are making a big impact. Rather, you can use the word IT rather than using computer, because IT hardware, IT software. So that is the answer for this gentleman's question.
Right. Thank you so much. That brings us to the end of this session. I'd like to ask our panelists if there are any conclusion remarks from your end about cancer care awareness in India.
I just want to say that the future of cancer care in India, if properly done through precision medicine, like what we talked about, India is a hub of technology now, which can be leveraged properly, bringing universal health care and also doing data collection using the technology, proper data collection will catapult us to a leadership role globally, and which we are very capable of. This is a huge opportunity and it's a need, and we should not miss that.
And from my side, I would say that companies like GE should invest more into Indian talent to do the basic research, so that we are able to indigenize and bring down the cost of our equipment to make it more tailor-made for our population and solve our specific problems, which if we are able to do it effectively, it will be a huge impact, or it will be a huge benefit or a gift for other countries in the third world, like in Africa and other things, who will readily adopt these type of inputs and many of this new way of looking. So I feel we are in the right place, and we all should join together, and we should all work together.
Thank you so much. Karan, would you like to add something to it?
Yeah, so definitely, I think both Dr. Ajay and Dr. Rangarajan have set the agenda for us as GE Healthcare. Clearly, Make in India is a key strategy for enabling oncology and in general healthcare affordability and access. As two examples that everyone knows, CT penetration in India today has increased a lot, and we've been the pioneers in making that in India. Similarly, for oncology, PET-CT, Discovery IQ, we were the first ones to start the production in India, and that has really helped increase the market. Definitely working with high volume, high density, and very well spread care providers like Tata and HCG gives us more strength, saying that we can take these kind of technologies to every nook and corner of India and continue to develop such technology, and coupled with not just hardware, as both of them said, but looking at increasingly using AI and digital solutions to increase precision, increase ability to connect even the remotest of corners, along with providers like HCG and Tata. We are very excited about what we can accomplish even more in the next 5 or 10 years in oncology space.
Thank you so much. I'd like to thank all our panelists, Karan Verma, Dr. Rangarajan, and Dr. Ajay Kumar. All of us, we came in with a lot of questions, but we're leaving this session with a lot of answers and a lot of understanding about cancer care management and awareness in India. Thank you so much for our viewers for joining us in this insightful session. Our recording will be available on YouTube, on Indian Express's YouTube, digital media handles, and other social media handles. So thank you so much for stopping by and hearing all our esteemed doctors and panelists. Thank you so much.